PFEIFER, a phenomenal surgeon. I've been working with him in many congresses around the world, and I hope you really enjoy his technique of optic capture, which has really changed outcomes. Vladimir?
Please, if you start my video, or I start.
Optic capture is the technique that we should use in pediatric cataract surgery. It allows us for clear visual access for the rest of the life of the patient, so it enables just one surgery. As you can see here, this is ideally flat IOL in the capsular bag, and then the optic capture is done. We are implanting the intraocular lens into the capsular bag, as you can see here, and we should use just a 3-piece IOL. We shouldn't use 1-piece IOLs in pediatric cataract surgery. So the lens captic is dialed into the capsular bag, and then the optic is pushed behind the posterior capsular axis. So we have ideal capture here, and anterior and posterior capsule can grow together and ensure us clear visual access for the rest of the life of the patient. Here is a case with the persistent feature vasculature, and in these cases the anterior and posterior capsular axis are very important. So we did anterior vitrectomy, cut the vasculature, and now we are implanting the IOL into the capsular bag. So the optic is pushed in the bag. Here the anterior axis is a little bit smaller, and now we are dialing the lens, trailing haptic, into the bag. Then one part of the optic is pushed into the capsular bag, and then the second part of the optic is pushed behind the posterior capsule. Now we have an ideal situation where the posterior capsule is joining anterior capsule, growing together and ensuring the clear optical axis. This is the ideal position or ideal way of implantation of the IOL in an infant or small child. This will assure us clear optical axis till the end of the life of the patient.
I would just like to add here that we do just one incision in the whole surgery, and then usually we need just one suture at the end.
So in all cases you do it, or do you have any cutoff where you wouldn't do a posterior capsular capture?
There are cases where I wouldn't do lens implantation, but if I have a situation as you saw here, anterior capsular axis, posterior capsular axis, that is a little bit smaller than the anterior one, about 4.5 millimeters, then I would go for optic capture always.
Okay. Do you do vitrectomy as well?
Yes, always. In all cases, I do anterior vitrectomy. Definitely, then take a triamcinolone, look for the vitreous if it is there. And what is also important, we implant the IOL in a little bit softer eye. So when pushing in the lens, the vitreous doesn't come out. So a little bit hypotopic eye, low pressure when implanting the IOL.
Can I ask everybody, how many people, if they can, will do optic capture in their pediatric cases? And how many do it most of the time? How many would do it more than 90% of cases? Your hand should go up.
Yeah, sure. Sorry.
Okay, thank you. So I think just a couple of, so I do it. I do it more now than I used to do it, but not in every case. In every aniridic case, I do it, because in aniridia, if the lens comes forward, everything decompensates. So in every aniridic case, I do it, but not in every case yet. My experience has been when you first start, it can be a little bit scary for people who are doing it for the first time. So I advise my fellows to make the posterior opening as big as the anterior one when you first start. Because it's a bit scary, you know, when you're putting the tension. But once they get used to pushing the optic behind the posterior capsule, then I agree. About 4.5 millimeter opening is what I aim for. But I think it's a really good technique, and thank you for sharing that with us. Anybody got any questions? Let's do up. Go ahead, and then I'll pass this to Shalja.
Sir, is there any age limit for your posterior fixation, or how do you modify your biometry for posterior fixing of this?
What was the
So it
question?
says, how do you modify your biometry if you're going to do posterior capture? Do you have to change it?
No, we don't change it. Usually in children, we aim for plus. So it's not important
Okay.
if it's
Overcorrection.
half the diopter more or less, because the eye will grow. And usually we do these surgeries. We do implant the IOLs up from 10 weeks of life of the patient, if the situation is like this. So we measure axial length and everything, but then we go much to the plus by nomogram.
Sir,
Can I just want to say, so we've looked at the biometry after we did optic capture. It makes no difference. And it's because the posterior capsule will contract and it pushes the lens a little bit forward. So for us, it's made no difference. We've not had to change it. We're going to ask Dr. Tibrewal, then we come back to you. One other question at the back, and then we'll get back to you. Just let her finish, and then you can have a question. Go ahead.
So I was asking that what's the rationale for doing an anterior vitrectomy along with the posterior capture? Because the posterior capture itself will prevent the lens epithelial proliferation or the visual axis opacification. Is it really required, or you can actually omit that step of anterior vitrectomy?
Can you do it without anterior vitrectomy? I always do it.
I do always anterior vitrectomy. The anterior and posterior capsule grow together, but there is this little haptic that stays.
Mm-hmm.
There the lens can travel, and they can travel behind. And if there is vitreous, then they can grow on the vitreous, you know. Then you can have an optical axis obscuration. If there is no vitreous, this just disappears. The same as if this will go into the anterior chamber. Mm-hmm. So I always do anterior vitrectomy.
And also, I think there has to be some pressure when you do this capture. If there is vitreous, it might come out in some of the cases. So probably doing it is much better. And you also have a space there, and there is no chance of rupture or extending of this capture happening. These are the advantages.
So we come back to the last question, if you want to get there. I was just going to say, we have another question.
The video that I saw, am I right that you did half of the optic in the bag and half was behind the PC? Or
No.
because he was saying that. Okay.
Both halves, both
Complete.
are behind the posterior
All
capsule.
right, okay.
Yeah.
So one more question, but Sholja, I was just going to say, for me, under the age of 12, I always do an anterior vitrectomy. 12 and over, I've been able to do it without an anterior vitrectomy because there's more space. But I think if you're starting, it's much better to do an anterior vitrectomy because there's less pressure and it's easier to do.
My question was, first question, what is the upper age limit of doing this capture in pediatrics?
There's no age limit.
In the pediatric, in all cases you do.
You can do capture also in adult if you want.
Yeah, okay.
It's no problem, or posterior capsular axis. But we usually do it up to 6-7 years.
Yeah.
And then we just do the posterior capsular axis and no posterior vitrectomy.